And the definition of treatment-resistant depression is basically that you have a diagnosis of major depressive disorder and have failed at least two different antidepressants. And so Spravato came on in 2019 as a therapy for treatment of resistant depression, but at that time it was only for therapy that was also paired with an antidepressant, so it wasn't for monotherapy. Most significant advances in the treatment of TRD, which was very exciting, but again, it was only for treating patients that also had some form of antidepressant or pharmacotherapy. So then in 2025, Spravato was then approved for the first and only monotherapy for TRD, not for depression, for treatment-resistant depression. And in understanding that, that's so now they're looking at ketamine being used without any other pharmacotherapy. And it just shows kind of just how important or how robust the response had to be to actually get ketamine as the first monotherapy. And so since then, we've had numerous randomized controlled trials that have demonstrated rapid antidepressant effects. And so we're talking effects within 24 hours to several days. And so when you recognize the success of ketamine and the fact that especially the speed of recovery, when you're looking at the amount of treatment-resistant depression, they say there's potentially 8 to 10 million people with TRD, and that's the ones that are diagnosed. And so now you're seeing ketamine treatment centers growing nationally. Um, so it's very exciting. It's not a question of if ketamine works. It's a question about what are we going to do with it now that we know that it works so well. And so you have all these centers growing, and now you also have to take a little bit of clarification. So our discussion is also to clarify the two delivery pathways for ketamine. One is the traditional psychiatric pathway and mental health model, which is what most of the research, the clinical studies, the clinical protocols, the trainings are mostly based off of that type of pathway. 90% of the treatment centers out there right now are psychiatric driven. A lot of it is insurance based. And some of the other, that 90% is also pain management. So that leaves about 5 to 10% of other therapies. Some of them are nurse practitioners that are in psychiatry nurse practitioners that have kind of veered away from the traditional paths, and the rest are functional medicine doctors and other wellness specialties that are adopting or adding ketamine into their practice models. But that's a big you have to understand that is that when you're looking and potentially interested in adding ketamine into your practice model, you have to realize of what the data is available. And so right now, a lot of the information when you go to look at various ketamine trainings or whether online or in person, a lot of it's going to be within the scope of psychiatry. And so our conversation today is what are we leaving on the table? When we're just looking through the psychiatry lens or through using ketamine just with pharmacotherapy, is there some opportunities that we haven't addressed? So when you look at the mental health directed model, ketamine is a standalone treatment or a treatment with other antidepressants. Their goal in that therapy is to treat depression. That's the scope of practice that they have is to treat depression, and it's important. Obviously, we know it works. They've shed a lot of light onto the success of ketamine and has opened the door for us to look at it a little bit deeper. So yes, they want to treat depression, and they look at scores. The PH9 is the depressive score, GAD-7 is the anxiety score, and the PCL5 is the trauma scores. So they're looking at reducing these scores, improving depressive symptoms, and decreasing the suicidal ideation. All very important. But is there another way or some other ways we can look at this other than just through this lens? So when we look at the way functional medicine approaches ketamine, we approach ketamine as more of a part of a treatment process. So yes, we want to reduce mental health scores, and I do believe that that's a good idea, is to, especially at baseline, is to get all three of those scores. One is for liability and basically justifying the treatment that you're doing, but the other is to see how people are potentially getting better. So I love that looking at mental health scores, and yes, we're trying to do the same thing. We're trying to reduce depression, we're trying to reduce suicidal ideality, but we're also finding that with ketamine, we can also help in potentially the quickest way to stabilize the nervous system. Right now, the modern patient that we're dealing with, which I'll talk about more, is riding in sympathetic tone. And so ketamine without a doubt, from what I've seen, is the fastest way to stabilize the nervous system. In that window of treatment time, you can also improve sleep quality, optimize brain function, build resilience, improve relationships, and restore health and happiness. That's that's kind of the goal and how you start seeing bringing in the functional medicine piece. So now if we look at this as a little bit of a case vignette here, you look at the mental health directed path for this patient, a 40-year-old patient with major depressive disorder, treatment resistant depression. They complete 5 or 6 ketamine treatments, experience a meaningful improvement, but then relapse several weeks or months later. So when you look at this client from a psychiatric lens, this could be considered a failed ketamine treatment because they've had 5 or 6 treatments, several weeks of improvement, and then they relapse. So a provider may say, well, you know what, let's change the pharmacotherapy, let's add another antidepressant, let's change it or stop one. They may or may not add ketamine back into the picture now because the patient didn't get the result that they had hoped. But if you look at it this way, from a functional medicine directed lens, now consider that same 47-year-old also had significant testosterone estrogen deficiency, hypothyroidism, poor sleep, insulin resistance, chronic inflammation, or severe nutrient deficiencies. If that same patient had all of those same qualities that they were either undiagnosed or not addressed, would that patient be considered to have failed ketamine? Or did biology contribute to the failed treatment, whether it's the medicines or the ketamine, or did it actually contribute directly to the cause of the depression in the first place? So this is an easy way to kind of look at what we're being potentially leaving on the table here. To me, we're only touching the surface of ketamine when you look at it through just the scope of psychiatric practice or the mental health model. If you're not addressing these other conditions, are you leaving that patient in a position for complete resolution, cure, remission, or healing? And so you look at both of these models together, traditional health, you administer ketamine, it decreases depression, you look for an achieved response or remission, and then at that point, you're going to decide if you're maintaining medications based on that response. Are you going to continue ketamine, or is that 5 to 10 treatments basically the ketamine opportunity that they have? If it doesn't work after that, ketamine's out of the picture and we're sticking to pharmacotherapy. From the functional medicine's perspective, we administer ketamine, we improve depression, but during that period of decreasing depression in that neuroplastic window or that capacity for change, we also utilize that window for optimizing biology. That's where functional medicine comes in: sleep, metabolic health, immune function, exercise, diet, hormones. And at that time, you also look, okay, now that we're optimizing biology, this is where you can start restoring higher functioning. Can you improve sexual function? Can you improve body composition even more? Can you get people over the hump so then they're at a point where they have a purpose and reason to continue all of the optimization you're doing on the biology to, one, decrease the chances of failing other antidepressants or ketamine, or at least stop the contributions of those disorders from what they might be that might be participating in the disorder or the disease in the first place. So when you're wondering about how ketamine works, I don't want to get into the biochemistry because that's a whole nother lecture in the first place. Getting into the NMDA receptors, the AMPA receptors, and brain-derived neurotropic factor, that's the biochemistry, that's leading what this neuroplastic window is. But I want to stay really clinical so we can get through this and have some questions. So just think of it this, is that neuroplasticity is the brain's ability to change and reorganize. And it's done through enhancing signaling, enhancing nerve pathways, and improving the signaling across those pathways. And when that happens, you get less rigid thinking. Old thought patterns become less rigid, new behaviors become easier to sustain. So think about that. These people in that 24-hour to several day window of plasticity where they're seeing this rapid antidepressant effect, it's because this is what's happening. So when you have a patient in this position, why not start influencing some of the other potential problems that could be contributing to the disease in the first place when they're in this specific window of time? And so this neuroplastic window, again, is 24 hours to several days. Some people have even said to weeks, but some of that has to be proven. But we can see it from our functional medicine perspective that we have an opportunity here. Because during these periods of advanced plasticity, the nervous system is more flexible. What that means is that The nervous system is supposed to go back and forth between sympathetic and parasympathetic tone. And today's modern patient is getting stuck in sympathetic tone. And when you're in sympathetic tone all the time or fight or flight, you understand that leads to hypercortisolism and other effects of chronic inflammation. So when the nervous system becomes more flexible, you start being able to get out of that fight or flight and start allowing the parasympathetic nervous system to do what it's supposed to do. And during this window, you start finding out the nutrition becomes easier. Exercise becomes plausible or possible. Sleep quality can improve, relationships can strengthen, and habits can change. So why not ride that window and provide more functional medicine to that period of time to see if you can get more improvements? And so I kind of like to look at it as a neuroplastic ecosystem because there are multiple factors that are all in play to keep this whole momentum that you have that's been started with ketamine. So you kind of start out with capacity for change. So between ketamine and neuroplasticity, you have this patient in ability or in a malleable state where they're actively able to start looking outside of the box or actually get out of these ruminating patterns or thought patterns and actually be able to make change. So during that, you also want to start influencing the biological environment. That's the hormones, the sleep, the nutrition, metabolism, inflammation, and gut health. And then after that, you need to have this person look at the purpose. They need to have a direction, a purpose, and an understanding of why exactly they're going to continue this biological environment they created so they don't backtrack or relapse into disease again. And so that's where relationships, purpose, mindfulness, integration, new behaviors, that's the part that locks the patients in. So at the end of the day, ketamine creates the opportunity, biology supports the opportunity, and then experience gives them direction and keeps them following with this path to keep them from falling back or relapsing into some of the suppression and anxiety. So it's more than just a neuroplastic window. You can look at this if you're doing things collectively, you can actually create a neuroplastic ecosystem that gives you much more time to continue to build. And you do that strategically by spreading out and organizing the ketamine therapies based off of their functional medicine approach. So when we look at this, we say, what shapes the biology? And this is here lies the difference of when we say, what if we're leaving something on the table? We already kind of gave you that little clinical case of a 47-year-old, which could quickly be thrown right down the mental health path of, they have treatment-resistant depression, they're on antidepressants, they go on ketamine and they fail. But we quickly showed that these people could also have some other conditions that could have been contributing to the failure of the treatments or actually contributing to the cause of the depression and anxiety in the first place. So when we look at these various factors that is right in our wheelhouse, this is what we do in functional medicine, we're going to start showing you how all of these factors actually have their own contributions to depression and anxiety in the first place. So when we look at inflammation, chronic inflammation, we say 85% of the population is metabolically unhealthy, meaning that they have some form of inflammation. It doesn't matter if it comes through obesity, autoimmune disease, sedentary lifestyle, poor diet. When someone has chronic inflammation, we know that that affects neurogenesis, neurosignaling, mitochondrial function, pretty much everything that could contribute to depression and anxiety. All of these conditions in themselves are tied to some form of mental illness. If it's not at the beginning, it will be at the end. So you can kind of see just attacking inflammation on its own has a high incidence of mental illness. When you start going into hormones, it becomes a little or much more obvious of what these opportunities are. Because when you look at some just women in general, which do have it dominate between the genders in both anxiety and depression, a woman in perimenopausal age has a 30 to 50% higher risk of depression or anxiety. And just that age group in general, we know has a higher risk of major depressive disorders. So, and you look at a man with testosterone, it doesn't matter if it's a youth with hypogonadism or, true hypogonadism or a man that's going through andropause. When testosterone is deficient, you also start seeing the symptoms of depression, sometimes anxiety, sometimes insomnia, anhedonia. And so we know hormones directly affect both depression and anxiety. Thyroid dysfunction. This goes back into psychiatry days where, when before the psychiatrists were able to treat depression, they also had to check out thyroid because hypothyroidism almost had exact symptoms of depression. And so they would check a TSH, they wouldn't check the rest of the thyroid functions, but they at least acknowledged that hypothyroid had a lot of correlation into depression to the point where they would actually ask, is this patient depressed sad or are they depressed tired? And over time, I don't think they really cared if they were depressed tired because obviously that would be a different path of treatment than antidepressants. But they're still coming out with, could hormone be contributing to depressive disorder? Lastly is the HPA axis. So, stress regulation, dysregulation, looking at cortisol, DHA, and pregnenolone. I already talked a little bit about chronic inflammation and hypercortisolism and how that affects, obviously relying on other adrenal hormones to balance out that stress response. But when someone's riding in high sympathetic tone, they almost certainly have some tie-in to the default mode network, which then causes ruminating depression and anxiety symptoms in OCD and other mental illness symptoms. So hormones directly tie to depression and anxiety as well. Then we look at the gut-brain axis, and as you know, most of the serotonin and dopamine, serotonin, 90 to 95% of serotonin is created in the gut, 50% of dopamine. And although those neurotransmitters that are created in the gut are not supposed to be able to cross the blood-brain barrier, they directly communicate through the immune system, the vagus nerve, and through other communication networks directly to the brain, affecting the brain's amount of serotonin and dopamine released as well. So anybody with chronic inflammation of the gut, inflammatory bowel disease, they have another 30 to 50% increased chances of having depression or anxiety as well. So much so that in 2016, they started calling it a disorder of gut-brain interaction. And that diagnosis is because they know there's a direct communication between the gut and the brain that is correlated with mental illness. Because the vagus nerve is the largest cranial nerve, and its communication to the brain is misunderstood by a lot of people because it's both afferent efferent nerve transmission, but 80% is afferent, meaning that the gut is sending 80% of the information to the brain, not from the brain to the gut. So the gut is constantly sending information to the brain. So you can imagine if you have gut disease, you're starting to bring down the vagal tone and you're instantly causing a disruption of the way the brain is communicating to the rest of the body, and it's going to compensate. So if the gastrointestinal system is failing, the brain is going to start compensating wherever it can to try to make the body function. That's what it's supposed to do. Inflammation also causes gut permeability issues. So now we start getting to nutrient deficiencies, and we know several nutrient deficiencies tie directly into depression and anxiety as well. And then the stress cycle just keeps it going over and over and over. So when you look at sleep, sleep is probably the most important factor in all of this and is one that's not heavily addressed as it should be. Because as you can imagine, anybody that's getting treated for depression, if they're getting treated, they're on multiple antidepressants, they try ketamine, and these people are failing, but they also have insomnia or they have sleep apnea that's not treated. So say a person has had poor sleep for 30 days straight. What person is going to be able to endure that without some form of mental illness, some symptoms of mental disease? It's pretty impossible. So then we talk about that modern patient again, and we look at circadian rhythm disorders. What's happening now is people are either using nicotine, caffeine, alcohol, right up until bed. They're looking at blue light screens, whether TVs, tablets, phones, right up until bed, and then they're going to sleep. Although they feel like they're sleeping, they're still not allowing that flexibility of the nervous system to get into the parasympathetic nervous system, which is the heal and recovery, and allow them to actually have recovery sleep, where this is resetting all the nervous system. It's improving, reducing inflammation, improving neurosignaling. That all happens during restful sleep. And so I always start with, if you do have a patient that is not sleeping, you're going to expect they're going to develop some forms of depression or anxiety in time if they don't have it already. I really focus very heavily on sleep hygiene because you can very quickly start to impact someone's sleep quality just by adding in good sleep hygiene. So I look at this as kind of the modern patient cycle, and this is what really changed my whole approach to ketamine, especially bringing it into a functional medicine practice. And what I have found is that the vast majority of my patients fall somewhere in this cycle. It doesn't matter if they're already with mental symptoms of depression and anxiety. They're already seeing biological decline with micronutrient deficiencies, hormone imbalances, chronic inflammation. Whether they're coming in with, where they've stopped working out as much, they're starting to make poor food choices, they have negative thought loops, they're just poor sleep. Someone will fit into this cycle, pretty much all of my patients. And when they do, it immediately alarms me to saying, okay, I get it. This is not something that we can't treat the modern patient the same way as we did 10 years ago. This modern patient is having new exposures and new contributors to their mental illness, and it makes complete sense. And now, after understanding this and understanding what I've watched with, applying ketamine over the last 15 years, is that there is a reason why ketamine works in functional medicine. It's because the patients are in this cycle, and it's very hard to break it. So when you look at the opportunity and you understand this modern patient cycle, and most of your patients fit somewhere into that cycle, it changes everything. It's because once I realized that my patients, my friends, my family, that you spend your time, you put them on a treatment plan, they leave for 3 months, they come back in 3 to 6 months, and you're like, hey, how you doing? And they're like, well, I haven't gotten to the gym yet. Well, I started eating a little bit better, but I'm running out of time. They have every excuse. They already know what to do. They just can't do it. That's where everything, basically a light shined, and I was like, I get it now. Because this isn't a knowledge problem. It's not discipline and motivation, or kind of, but it's a capacity problem. These people know the problem, and when you really sit down going, why are you not able to succeed? They get emotional, they're embarrassed. Some of these people were former athletes, some of them were in the best shape of their lives 5 years earlier. And why are they stuck in this cycle that they can't get out of? They know exactly what to do, they could pass a test about what they need to do, but yet they're still stuck. And that's when it all made sense to me. This is not a problem of knowledge, it is a problem of capacity. And it kind of brings this question to the right there, where it says, well, now can functional medicine reach its full potential without ketamine therapy? It's almost a reverse of the question that kind of started the whole conversation. And my answer is that no, I don't think you can reach functional medicine's full capacity with this new modern patient cycle, because it's so hard to bring down that nervous system and to get people just over that hump to where they can actually start actually contributing to the therapies that you're laying out. And so that changed my model forever. So now when you start thinking about integrating ketamine into your practice, and what that would look like, you have to think about what your clinical goals and your practice benefits would be. Well, just remember, these patients are stuck in a cycle. You can keep pushing peptides, you can keep pushing hormones, diets, eating, all these eating strategies, you can get them on supplements. If they don't have the capacity to change, you're only getting a little bit into their full potential. And so with ketamine added on board, your clinical goals, better outcomes, check. Yes, you get better outcomes, because as soon as you can bring down the nervous system and take that capacity to change, they start doing the therapies that you laid out, and they start improving their biology. Once the biology starts improving, then they want more. Now they're looking at, getting into some of the more progressive parts of functional medicine, which is improving sexual wellness, really diving into body composition, really getting them into a purpose, understanding that they can get their vitality back, and they're starting to really want to increase their health span and longevity. Now you have a true functional medicine patient that's actually getting the results that you expected them to have. So how does that roll over into practice benefits? Well, longer term relations, absolutely. When you have someone that you can give this type of improvement to, I could give you a kind of a quick analogy. This is very similar to anybody that's using GLP-1 peptides. If you have one of those patients that are using GLP-1s correctly, say they couldn't lose 30 pounds, 40 pounds, they've just been stuck, they're sad, they're in tears, they just could not get that weight off, even though they've tried and they really want the weight off. When you give them a GLP-1, some of these people go, oh my gosh, thank you. My food noise is gone. I'm at the weight that I've been wanting to get to for the last 3 or 4 years. That's the same type of success you can see in your practice. When these people are struggling, they're just stuck. They know what to do, they just can't get there. And then all of a sudden, they're making progress again. They're thinking clear, the brain fog's gone, they're engaged in exercise, they're back having sex in their relationship's getting better, their life's getting better. This is the same type of situation, but at a higher level. And so relationships get better, there's higher retention. These people are locked into this ecosystem now because they know this is what is leading to them not having depression and not having anxiety, despite if they're on antidepressants or anti-anxiety medicines already. So of course, when people start feeling better and they start getting the benefits that you're laying out, they're going to start talking to more people like, oh my gosh, you guys got to go do this. And that's where we're going to start seeing momentum in the functional medicine arena as far as ketamine goes. You have to start delivering it so you can get the patients understanding how it works, and then they can go tell their friends and other people around them that are stuck as well, which, is most of the population at this point. And you can really start building a functional medicine around ketamine. So, final thoughts, and so we can get into some questions, is our goal is far more than treating disease. It's helping people reclaim health and happiness. So this new modern patient requires a new modern approach. And so again, when you look at your functional medicine practice, you will have your patients that leave and they're saying, "Oh yeah, I'm doing so much better." But are they doing as good as they could have if you started adding in ketamine to where you can start improving the brain function? Because remember, you can't, progress is impossible without change, and you can't change anything without changing the mind. And so, to me, my practice now is completely centered on functional medicine with ketamine. All my patients, I at least have the discussion with, or I should say, not all of them, but most of them, I have a discussion about ketamine, especially if they're in between the age of 40 and 70. Especially if you're perimenopausal or if you're a female after the age of 40, it's almost 100% of my clients. I at least mention ketamine to them because females dominate dementia, they dominate depression, and they dominate anxiety. And it's all because of hormonal makeup. They dominate fibromyalgia, chronic fatigue. So when you start looking at how you can use ketamine to build your practice, you have to understand the patient that you're treating and understand that they're up against a little bit more than we with the technology than we had to deal with, well, even the world than we had to deal with 10 years ago. So I do find that you can really find an opportunity to build a functional medicine practice off of ketamine, um, just based on the information. And I hope that I at least distinguish or clarified the two paths and what is out there. And I wanted to leave that open for some questions because I know this is a pretty hot topic.
That's great. Thank you.
If you don't want to unmute, you are more than welcome to type your questions in the chat, but we would love to have you unmute if you would.
Yeah, and I'm sorry I went through that fast just because usually we don't have any time for questions, and I know this is a lunch and learn and a Q&A, so I gave a high view of kind of where we are with ketamine and the opportunity we have. So hopefully people do have some questions because I could have kept talking for hours.
I know we have one person that is already offering ketamine therapy. Is there anyone else here that is currently offering ketamine therapy?
Not offering, but I know clinics who are.
You know, clinics who are.
Yeah.
Yeah,
Have you?
so if there's no questions, I can kind of continue with some words of encouragement. Is again, I've been doing functional medicine for 25 years, and I've been doing ketamine for 15. I've studied ketamine dating back even farther than that. And in medicine, providers only get certain opportunities to make drastic change with their patients. And in my 25 years, I've really only seen a few opportunities like this. One of them was growth hormone, or even growth hormone secretagogues in the peptide world. Another one was stem cells, and then ketamine. But ketamine, by far, without a doubt, has been the most impactful therapy that I have provided to my patient, my parents too, my patients. Um, Without a doubt, there's just no question that ketamine is here to come because once you heard the other physician, well, some of you weren't on here, when I asked him how ketamine's going in his practice. He's been providing it for 6 years, and he said, absolutely amazing. Great drug, great response. The patients love it. That's what you're going to find is that, when you offer an opportunity for someone to kind of get from point A to point B a little bit quicker, that's what our society wants right now. Everyone wants immediate gratification. So if you can provide that hope after one treatment, just like someone with suicidal ideation, 24 hours, within 24 hours, this person's depression or suicidal ideation is gone. And most of these cases are a high percentage of them. So just think of that neuroplastic window that can take someone from wanting to potentially die to not wanting to kill themselves in that short of time. So if that neuroplastic window actually is 24 hours to several days, and you can compound on that, just think of what you can do with that client when they start realizing that not only do they not want to die, they want to live. What else can you what else can you pull out of this situation to get this person so they're so far from wanting to remove themselves from this world that they're actually thriving? And again, it's not whether ketamine is coming, it's here. It's already here. You can see the FDA is improving Spravato for new treatment outcomes or treatment considerations. Psychedelics are already making moves behind the scenes. I said Eli Lilly just bought a DMT, which is basically the main ingredient in ayahuasca. Bought a DMT company for a couple $1 billion. They're already doing research on analogs of LSD, MDMA, and psilocybin. So when you go back and look at the data of psychedelics, from the 1930s to 1970s, you have 40 years of information that is going to support the conversation we're having now. It's just ketamine is the only legal one right now. But all of the data was supportive of basically opening the door for us to utilize it in functional medicine. It should be very clear now that going back to that patient, if you're just offering ketamine in combination with antidepressants, and you're not addressing any of those other factors that contribute directly to depression and anxiety, almost with a direct cause or at least a contributor to the disease process in itself, it's pretty obvious. I mean, and so then now that I've been kind of pairing ketamine in functional medicine, it has just absolutely opened the door to so many new possibilities. I mean, you're going to start seeing ketamine being used in physical therapy, and various joint manipulations. Just a little bit of ketamine, you're going to start seeing it being used in more aggressively in non-psychiatric counseling. So if you haven't considered ketamine and you're in functional medicine, it's one of those things where you really have to start thinking about it. It's just similar to when orthopedics were put in the position to adding stem cells or regenerative therapy to their surgical centers. Well, if patients didn't know you were offering stem cell regenerative therapy, then they're going to think, well, why are you just trying to do surgery on me? Why aren't you offering these type of therapies? So in the long run, people that are late adopters to ketamine and functional medicine is going to find themselves trying to catch up versus being on top of it and at least trying to understand it more. And also just be careful because again, when you start going and looking for training or information or protocols or research on ketamine, you're going to find that it's mostly skewed towards the psychiatric or modern or mental health model. Not that that's bad. It's just you're not going to get the same type of information from some of the functional medicine treatments that we provide.
Got a
So we,
question. Oh, sorry.
oh, it's okay. You can go. We had a question in the chat. So
Oh,
they wanted to know, are you only using, I'm going to say this name wrong.
Spravato?
Spravato? Yeah. Or are you also offering IV therapy? Do you see a difference in response if you were offering both?
I offer all of it, but most of my treatments, excuse me, is based off of infusions. We do injections as well. I think infusions is the gold standard. I do think Spravato is very good for people with chronic pain, and can be used with people with chronic depression as well, and it's been used successfully. I have patients that have been on Spravato or a compounded version of ketamine for months or years and are doing great. But from a functional medicine lens, again, when you start looking at all the tie-ins between inflammation, gut disease, sleep disorders, hormone deficiencies, micronutrient deficiencies, in my mind, I'm trying to keep people from any sort of daily therapy regimen. I'm hoping that we can utilize functional medicine and ketamine together to get people to a point where they don't need to take ketamine every single day. That's going to be very individual, but both of them are very successful. But I do believe that if you're offering both of them together, that you can achieve the success without having to do the daily Spravato.
Dr. Agin. Robin?
Yeah, so I was wondering, are you only offering this to people who have already tried two antidepressants, or are you doing this in general in your practice in functioning medicine as a whole?
Yes. So that was the big distinction is that that is the psychiatric model is they're following, the use of medications because that's what, traditional psychiatry does. It's pretty pharmaceutical based. So no, I'm not, I don't use those standards at all. I'm looking at ketamine as potentially, uh, as something that can reduce the chances of having major depressive disorders. Because remember, a lot of the people that come in, I only have a small percentage of patients that come in to see me for hormone therapy that have a perfect diet, they're exercising all the time, their body weight is ideal, their sleep is great. They have really no complaints other that they just need hormones because they want to optimize or replenish their hormones. Most of my patients are coming in because they failed traditional medicine and they're like, hey, someone told me to go in and try, this cash-based solution because remember, everyone's used to using their insurance. So I get most of my patients come in and they have some complaint, at least one, and they usually will fit into that modern patient cycle. They're somewhere in it already. It's just how severe is it? How old are they? And how fast are they moving through it? And so I take all these patients and I see them, and I already know, I mean, you can document they're headed into a major depressive disorder if you're not going to make some change right away. And remember, a lot of them, they already know what to do. They wouldn't have come in and have to spend, extra cash to see a provider to give them more accountability and potentially more information. But they already know they have to improve their sleep, improve their exercise, start eating better, lose some weight, improve their sleep cycle, manage their habits. And so this is kind of what I'm saying is that most of the patients that come see you lack the capacity to fully engage in the therapies that you're presenting to them. So once you bring ketamine on board, all of a sudden they're in that plastic window or ecosystem where now you can start saying this is, and so I'm very transparent now. I will show them that cycle. I will show them the treatment plan. I'll show them where they're at. I'll tell them exactly what ketamine, why we're using ketamine. And for most of them, especially the females between the ages of 40 and 60, 40 and 70, most of them are riding in sympathetic tone. So just explaining to them that the first thing that we're going to do is try to bring the nervous system more flexible and allow them to start feeling that they're not wired and tired and just stuck and beat up to where they actually feel that their brain fog is gone, they're thinking clear. That clarity is the hope they need. And that can happen after one treatment in that 24-hour to couple day plasticity window. They immediately have hope. And that's all you're trying to get out of this first treatment is just to give them hope. And so you almost have to manage this before they get to the point where they need antidepressants. Those are the ones you're trying to grab onto, are the ones that are starting to say, yeah, I'm just not feeling well. I'm not myself. I'm sick of it. I just need to do something because I'm starting to get really nervous on the path that I'm going. Boom. Those are the ones you jump on before they even have to go on antidepressants. And I'll expand on that as I get patients that will come into me, and this happens multiple times. They come in to see me and they tell me the reason they're there is because they just went to another physician and or their primary care doctor, and their primary care doctor was just about to put them on an antidepressant, an anxiolytic, or a sleep medicine, and they don't want to take them. So they're just coming in to say, I don't want to take these, but I'm desperate. What do you have to offer? What can we do? And that's the point where I love because if you jump on these people right away, most of them never even have to touch the medicines that they were prescribed because they don't end up needing them.
Good to know. Thank you.
Mhm.
Yes.
Can you hear me?
Yep.
Yeah.
Hey, I have a quick question. So, being a functional medicine provider already, I'm interested in bringing ketamine into my practice, but I'm a little hesitant because I don't want to attract the whole psychiatric world of it and more use it for kind of like how you use it for. So, do you think that's an option to be able to work around that, not trying to attract depression, suicide, and then do you train on that?
Yes, absolutely. That is a phenomenal question, and I'm so glad you brought that up because herein lies my initial problem. So when we first started advertising ketamine, what exactly you're saying is what we ended up with. We ended up, with some really severe psychiatric cases. One was because we actually are pretty affordable with our ketamine. But to your point, that is exactly what I was not wanting to bring in because some patients do need a higher level of care. So when these clients are coming in on multiple antidepressants and these family members just happen to find you that you're delivering ketamine, I had to change my model. And so we have a very strict screening process. And that's kind of what we train on the Institute of Mindful Medicine is functional psychedelic medicine. And so our screening process is built to defer those patients that need higher level of psychiatric care. So if people have immediate suicidal ideation, we take those on a case-to-case basis, and that all goes through a screening process. But if people have too high a level of psychiatric illness, we don't accept them into our practice because we aren't a psychiatric clinic. So you are able to kind of triage or field the patients that would be more suitable for a functional medicine practice. And we actually do tell those patients saying, hey, right now you don't really qualify for our type of functional medicine approach. You need to be more stable. So we actually refer them to some of the psychiatric driven models that a lot of those models, the psychiatrists or psychologists actually sit in with them during their therapies. They do assisted psychoanalysis. So during their ketamine treatment, they're actually doing psychotherapy. We say that you can go there initially, and once you become more stable, then we can take you into our program. So that's a great question, and absolutely, you can practice the way you want and really have a strong screening process to make sure that you get those patients and that you're not taking on a patient that might be too much for your clinic.
Awesome. Thank you, Dr. Agin, for answering that. Does anyone else have any questions on anything Dr. Agin's gone over so far with functional therapy and how it will affect the ketamine therapy? Or we're also always open to any functional therapy question or any other just implementing questions on even how to get peptides implemented into your practice.
All right.
Or IVs. IVs are very popular as well.
Yeah, and you're going to see,
Yeah.
just to kind of expand on ketamine, ketamine is already expanding in the backgrounds again. There are a lot of companies, I can think of three or four that are already offering microdose ketamine and troches. The microdose there's a company called Joyous, there's Mindbloom's been out there, but you're going to see that these telehealth-based ketamine centers are going to continue to grow. I do believe they're going to become more regulated because right now I think it's a little loose in the way they're managing home ketamine. But we're already piloting a home ketamine model that we're utilizing. But for patients to qualify for that, they actually have to come in and be seen, have an established relationship with a physician, actually have a certain number of ketamine treatments before they could qualify for doing home therapy. And I do think home therapy is going to revolutionize mental health because when we talk about the nervous system, you can imagine the better the nervous system is, the more flexible it is and the more able you are to get out of sympathetic tone, the better the treatments are. So in our situation, a lot of times people are coming right from work, they're driving right from their cars, getting into our office, sitting for 20 to 30, 15 to 20 minutes, and they're back in a room doing ketamine. In a perfect world, these people would have an hour to turn off their phones, do some stretching, do some journaling, relax, bring their nervous system down, and then go obviously do a treatment in their own home in the comfort of their own bed. And to me, it's really rewarding to be able to get someone into that position because I do believe that they're going to have much stronger treatments and then a larger ability to then integrate after when they're able to just walk in and get a pad of paper or sit outside in the sun and just reflect and relax and be able to kind of integrate or at least consider things that they're going to be able to do in their lives to keep their momentum going.
A question for you. I've noticed these online places are trying to, I see them advertising um, at-home shots. That
Mhm.
sounds a little risky to me. What do you think?
Yeah, that was what I was just discussing. And so I agree with you completely. I think Mind Bloom's the main one that does the home injections, and they do it all through surveys and through a Zoom call with a nurse practitioner. But I'm not sure. Do you do injections in your office or just infusions?
Both.
Both. So you've seen the difference between an injection and an infusion. And so my concern is the same, is that sometimes if people haven't had an experience, a home injection without any previous therapy in under guidance by a physician, I think is a little challenging because it could tarnish the whole experience for that patient if they have something was a little bit more intense or something more than they were planning on. So
Yeah,
I believe the model should all be based on a physician-patient relationship and that they have to have those treatments done in an intra-office first
I
before they
agree.
go home
I
treatments.
agree. I was just surprised to see that.
Yeah, so was I. And they've been doing it for a while now. And I don't know how many, I can't find the statistics of how many patients they have on the injection side, but I know they do a lot with the oral troches.
Now, I do have patients on oral ketamine troches as well,
Hmm. Yeah, I do
and
too. I do too. And
it
I
seems
actually
to
like
work.
them better than the nasal spray.
Yeah. How do you find your patients? That's the problem I'm having, is finding patients for this.
Well, fortunately, I have a functional medicine practice. So as I've said, I've converted to my functional medicine patients are going to hear about ketamine. The ones, unless they're ones that in that small percentage that don't need to have that conversation.
Uh-huh.
But I'm able to, and remember, I've been doing this for quite a while, and you do, just like most practices, word of mouth is your best advertisement. And it just happens to be, as you know, with ketamine, after people do ketamine after their first few treatments, all they can do is think about how many other people need this, and so they're out there advertising. The problem is that there's still a stigma on ketamine because of the recreational use. They don't understand it's
Uh-huh.
not really an addiction problem. It's just an abuse problem, which a lot of drugs
Right.
are. And that's where I'm really hoping that we can start building off of these types of webinars and lectures so that we get more people understanding the safety and just the utility of this drug, so that we start, getting more and more clients in here because it's needed. I mean, people need this. It really is an entry point for people to get to where they want to be and shut that duration of time that it takes to get where they want to get. So I'm hoping that, with some of the changes in some of the viewpoints in mainstream media, that we might actually start seeing clients start, reaching out and making the phone call and coming to us and not us having to try to keep reaching out to find clients to help.
Uh-huh. Okay.
Hey, Dr. Agin, can you hear me okay?
Yes.
So I have a colleague of mine who has a Scenic City neurotherapy, and I don't know if it would fit anyone's model, but he has a contract with the VA, and I think that's worked out well for him, and of course collaborating with psychiatry. That's another good way to get referrals.
Yeah, absolutely. We do get quite a few referrals from psychiatry and psychologists,
Mhm.
especially the psychologists. But yeah, we do have a good referral from some of the psychiatrists here, and then we also have a referral system set up with one of the mental health modeled ketamine centers. They send us the patients that don't have as much mental disease. That would fit our model a little bit better. And likewise, we refer people that we screen and find that it would be better for them at a little bit higher level of care, and we send them to some of these other therapies that are run by psychiatrists. So that's a great point, and
Hang on a second.
and you mentioned the VA also. We
Yeah.
we are working really hard at trying to help more and more of the veterans out. We were working with a nonprofit organization called Crusaders for Hope. They were helping bring us some patients, but they've been a little bit quiet lately. But unfortunately, the VA and a lot of the patients that are veterans, are heavily reliant on their insurance. And unfortunately, in a lot of the functional medicine practices, we don't deal with insurance. So a lot of
Gotcha.
times the VA is limited just because of them having to actually. But I'm really happy that the VA is starting to look at ketamine and even cannabis for people that are on, on multiple medications or taking opiates for chronic pain, and starting to look at CBD, cannabis, and ketamine as an option for them. So
Mhm.
that's great because our military are ones that just do so amazing, the ones that we can get in here.
Yeah.
So is the VA covering ketamine treatments now?
Apparently, they're starting to. I still think that they're offering it in a mental health model. So they're still doing it with pharmacotherapy on board. They're not doing it as a monotherapy, um,
Mhm.
even though it's approved for that. So it's still to me, and they're not bringing any of the functional medicine components in there. That's where the magic lies. We already know we can change someone with just functional medicine. We can improve their outlook. We can improve their depressive symptoms, their anxiety symptoms, their insomnia. Just imagine adding ketamine into that. That's like that magical combination that I don't see, I'm forecasting is going to be the therapy in the next 5 years.
Mhm.
It's the writings on the wall, but right now, again, when you're dominated by the mental health model, I think that there's a lot of room for functional medicine to come in and actually start really either working with psychiatrists and managing the functional medicine part if they're doing the ketamine therapy, or doing the ketamine therapy yourself. But there's a lot of different strategic ways you can help people and build this model, even if you don't want to offer ketamine in your office. Start like someone said, start working with psychiatrists. You take care of the functional medicine, they take care of the ketamine.
Okay. Okay, great.
We only have a few minutes left. Are there any other questions on either ketamine therapy and how to use functional medicine to make it truly amazing, or anything on peptides, GLPs, hormones? Any question is welcome. And then if not, Dr. Agin, is there anything else you would like to say before we close?
No, we're going to continue to pound this subject over the next 6 months. So hopefully, we'll get more and more people looking at this after the fact, and hopefully, get some people that want more information, because I can go very deep into ketamine therapy, get into the biochemistry, and a little bit deeper into the physiology as well. But you got a good picture of what ketamine does and how it opens the windows and works nicely with functional medicine. So it seems to me it's kind of that last pillar that's been missing. Because the mindfulness of medicine really is the driver. So when you can impact the mind, patients are much more apt to be successful. So just keep your minds open, and definitely consider where you want to take your practice, because it's definitely heading in that direction. That would be my last words.
A quick question. Do you go deeper into those topics with the Institute of Mindful Medicine certification training?
Yeah, so that's what someone asked, is do we train on that? And yes, we started the Institute of Mindful Medicine based on the idea of combining functional medicine with psychedelics, not just ketamine, but all psychedelics. And in that, we train on how our practice, screens, how we manage documentation, how we approach the patients through our surveys, and then also how tying in foundational functional medicine through a process of stabilizing, restore, transform, optimize, and then maintain. And it's a nice program to get people understanding how to deliver ketamine. The other thing that we do in our training is that we have an experiential experience. So the people that train with us, I require them to, unless they have a medical reason not to actually have a ketamine session themselves, because it's really hard for anyone to understand the process or the opportunity without having an experience themselves. So they get really hands-on training, but also medical support for months after to really help them build their practice.
Thank you so much, Dr. Agin, for talking to all of us. Thank you, everyone, for coming. And we
Thank you.
really appreciate your time.
Thank you. Thank you.
All right. Thank you, guys.
We'll
Yep.
see everyone